All right, good morning, everyone, and thank you for being here. So I'm a pediatric nephrologist, so I spend a big chunk of my day talking to families about and patients about the kidneys, what they do, what happens when something goes wrong, and how to treat different manifestations of kidney disease. I have special interest in mitochondrial disease and glomerular disease. So a few months back, I was talking to a medical student who, for the first time, attended a kidney transplant procedure. And the procedure is amazing. They essentially, the parent donates a kidney to the child, and the kidney is inserted in the lower abdomen. Usually, most people think that you would replace the kidney and put it where the kidney is. Actually, they leave the native kidneys in there, and they insert the new kidney in the abdomen. And, asking her like what was most interesting and what was surprising for her, what she was most surprised with is how small the kidneys are. So that's not something I expected, but it is actually, if you look at most textbooks, the kidneys are drawn much, much bigger than what an actual kidney is. An actual kidney is just the size of your fist, in terms of size. An adult kidney is maybe 4 or 5 inches in length, maybe 2 inches in width. And the kidney just weighs about 4 to 6 ounces. So just, a few tennis balls, essentially. So it's interesting to know that even though the kidney weighs that much, which is about 0.2% of our weight, it gets 20% of the blood flow. So 20% of what the heart pumps goes to the kidney, which is essentially like 100 folds of what you expect based on the weight of the kidney. So there's a couple of reasons for that. One reason is obviously the kidney needs to fill the blood. All your blood volume, those 4 or 5 liters of blood volume, have to go through the kidney about at least 40, 50 times every day to maintain fluid balance and to maintain electrolytes. So why that much? Another reason, and actually I want to point out that, this amount of blood flow is unique because only the liver gets more blood flow than the kidney. And in terms of the liver has a much, much bigger size than the kidney, just that in mind. So the other reason is that the kidney is highly metabolically active, which means that it needs a lot of oxygen. In fact, if you take ounce for ounce, the kidney is only second to brain tissue, to neurologic tissue in terms of oxygen consumption. So there's a lot going on in the kidney to try to use oxygen. And, when we know, we're all here familiar with mitochondrial disease, we know that the mitochondria is like the factor in the kidney that help create energy and use oxygen. And it's not surprising then that kidney disease is one of the most common manifestations of mitochondrial disease as well. So, if there's one thing that I would want you to take home from this talk is that what's the most common manifestation or presentation of mitochondrial disease affecting the kidney? The most common is actually no symptoms at all. So in the largest series that they did in Europe, which in mitochondrial terms, because it's a rare disease, it was about 42 patients. So more than half those patients had no symptoms at all, and it was detected on blood work or urine testing. So only 8 patients actually had symptoms related to their kidneys. All the others were just detected on blood tests or urine. So if there's one thing, if I'm able to convince just a few of you today, parents or patients, of how important it is to actually screen for kidney disease, and that kidney disease is actually, even though in advanced stages it's not reversible, it's still treatable. There's treatment of the manifestations, there's treatments that actually help slow down the progression of kidney disease. So you don't end up developing symptoms, which at that point is usually late in terms of kidneys. So there's a few things before we start talking about the manifestations. I want to point out there's a large group of KDIGO, which stands for Kidney Disease Improving Global Outcome. So this is an international group that gathered in a conference and looked at different terms related to the kidneys. So you can imagine they looked at no research. They just wanted to know what to call each different manifestation of kidney disease. So they came up with up to kidney terms that are becoming more and more used. And we're trying to kind of phase out those old terms. So for example, the term end-stage kidney disease, it's still used by some nephrologists, but ideally, there's nothing end stage about when you develop loss of kidney function. So it's just a transition. There's now, an options meeting that we meet with the families and we talk about the next steps of treatment if you have close to entire loss of kidney function. So instead of using end stage kidney disease, we would like to use the proper terms, which is chronic kidney disease of advanced stage, like stage 5 or stage 4. And the same thing goes for pre-dialysis or kidney failure. So kidney failure is also a term that is old, and we're trying to replace it with a more appropriate term of acute kidney injury. And this essentially describes what's happening if your kidney is all of a sudden shut down and there's a potential for reversible kidney function. So you could still recover from it. That's called acute kidney injury. And then if the loss of function persists beyond 3 months and becomes chronic, then we would call it chronic disease. And I'll talk into those terms in more detail. We also want to avoid the ambiguous terms that are, some patients are not familiar with, like renal, and just use kidney, which is most people know what a kidney is. And finally, using terminology that makes prognostic sense, which means it can predict the future. Just know what the kidney, where the kidney function is, compared to a normal function. So is it mildly reduced? Is it moderately reduced? Or is it advanced? Usually mild kidney disease is stage 2 or 1, moderate is usually stage 3, and advanced is stage 4 or 5 chronic kidney disease. So I'm going to start, obviously we talked about why mitochondrial disease is common in kidney manifestation are common in mitochondrial disease, and it's listed right away in the guidelines, those guidelines in 2017. These are actually consensus-based guidelines, unlike diabetes or asthma, for example, where hundreds of thousands of patients can participate in clinical trials. Mitochondrial disease is very uncommon. So most of our evidence comes from case series, which means a number of patients that were described in a clinical study, or small controlled studies. But unfortunately, I don't think this is going to be like the level of evidence to get to randomized controlled trials on hundreds of thousands of patients is not feasible, and it's not going to happen probably in the near future. So in the guidelines, the first sentence does state that the kidneys contain a high density of mitochondria, particularly in the cortical tubules. Those are the first parts of the nephron. But all sections of the nephron may be affected by mitochondrial disease. So nephron is just the cell that forms the kidneys. The cell is the main cell that forms the kidney. So what are some of the common kidney manifestations? So you can see there's a lot of different manifestations of kidney disease. One of the most common is renal tubular acidosis and Fanconi syndrome. So this is when the kidney is not able to regulate acid-base balance properly. But almost any type of kidney disease could be related to mitochondrial disease, including nephrotic syndrome, Bartter-like syndrome, a condition called tubular incision nephritis, and even calcification, stones, and cysts. So all those could be seen in chronic kidney mitochondrial disease. And we will be, for the next 30 minutes, going through some of those presentations one by one and discussing them in more detail. So before we go into that, each manifestation is related to loss of one function of the kidney. So what are the functions of the kidney? The first function that most people are familiar with is clearance. So the kidney essentially cleans the blood, clears waste products, clears toxins, and that happens at the level of the filters, which are called the glomeruli. These are specialized blood vessels that are clumped together that we call the glomeruli. And this is where the primary urine comes out. And, each day, about 144 liters of urine is filtered in those glomeruli, but we only pee out 1 to 2 liters because most of it gets reabsorbed. Most of that fluid gets reabsorbed in other parts of the kidney. The second part is the tubules. So there a proximal tubule, that first part, and then a loop of Henle, that's a big loop that goes down and up. And then the last part is the distal convoluted tubule. And then there's the collecting duct that collects everything, all the urine from every nephron. So those have important functions in regulating electrolytes, sodium, potassium, acid base. And those are, especially the proximal tubule is the most rich in mitochondria. So you expect that if there's mitochondrial disease, this is the first part that's going to be affected. The kidney obviously have a very important role in regulating blood pressure. The way it does that is through hormones called renin, angiotensin, and a hormone called aldosterone. So it fine tunes the amount of salt that goes into the urine, and that's how it regulates the blood pressure, and also releases hormones that constrict or dilate your blood vessel. So it helps you raise or lower the blood pressure depending on the needs. It also has important roles in bone health. So the kidney is very important in regulating vitamin D metabolism. So vitamin D is made in our skin, it's converted to a different type in the liver, and then finally it gets converted in the kidneys to the active form of vitamin D that actually does its function. So when the kidneys start to, over time, lose function, that's one of the things that is important to replenish vitamin D, but also sometimes provide the active form of vitamin D directly. So bypass that activation that happens in the kidneys. And obviously metabolic bone disease, if you've heard that term, almost any patient who have chronic kidney disease will have some degree of metabolic bone disease that we manage with medications, or early, sometimes it's just diet. And finally, the kidney has a role in making red blood cells. So the kidney creates a hormone called erythropoietin. It senses even slight differences in your hemoglobin, your blood counts, and those reduce in the blood counts when you get anemia, gives a little bit less oxygen to cells in the kidney that release this hormone called erythropoietin that actually tells the bone marrow to make more red blood cells. So it has a role in that fine tuning of how much red blood cells are made in the bone marrow. All right. So we'll start with the glomerular, the filter. So the filter is what determines how much blood is actually being filtered. This is called the glomerular filtration rate, and this is the main measure of kidney function. So we check certain substances in the urine, in the blood, like creatinine, but then we use that creatinine to actually calculate how well the kidney is filtering, and that's the glomerular filtration rate. On average, the glomerular filtration rate is around 100. It varies between 90 to 120 or 30 is considered normal, but when it goes below 90 consistently, that's a loss of kidney function. So as you can see, there's three signs of early kidney disease or loss of kidney function. So one is acute kidney injury we talked about, is that the drop in that GFR that is acute, there's a potential for recovery, and it's less than 3 months. And then if that persists and becomes chronic, we call it chronic kidney disease. And then proteinuria, which is elevated urine protein, is an early sign of kidney disease, sometimes the earliest sign of kidney disease, even before the GFR drops, or the patient, we see any abnormalities on blood work. So just urine analysis that detects proteinuria can actually be a signal of kidney disease even before anything else is abnormal. Normally, the kidneys should hold on to protein in the blood and not leak it into the urine. In most cases of kidney disease where the filters, the glomeruli are affected, you get this leakage and you see elevated protein. Particularly the albumin is the protein that signals glomerular disease in the urine. So there are different types of proteinuria that we will talk about soon. Sometimes proteinuria is related to just glomerular, which means a problem in the other parts of the nephron and not the filter, the glomerulus. And we can talk about how to differentiate between the two, because the treatment is very, very different and the implications are so different depending on the type of proteinuria. So this is acute kidney injury. So one of the issues with mitochondrial disease is that not only, having less mitochondria means they have less energy in the kidney, so you have less ability to regulate electrolytes. But also when you develop an injury, because the kidney is so powerful, it needs so much oxygen all the time. So it makes it the vulnerable organ when you have reduced oxygen, whether it's bleeding, whether it's dehydration, whether it's low blood pressure, like from an infection, or heart failure. Any cause where there's decreased blood supply to the kidneys, it's going to be the first organ that gets damaged and gets injured. The other issue with mitochondrial disease is that when you recover from AKI, the mitochondria is so important for recovery from AKI. So if you have issue with mitochondrial disease, not only you're at risk of acute kidney injury, but your recovery from acute kidney injury is generally not optimal. So you could progress to chronic kidney disease faster if you get a lot of episodes of acute kidney injury, unlike patients who have intact mitochondria might recover much faster and actually not lose function after a few episodes of AKI. So this is how we diagnose acute kidney injury. I apologize that I flipped those columns. So creatinine is actually the first column. So in stage 1, you have a 50% increase in creatinine. And we get a lot of questions from families that the creatinine went up by a fraction, 0.1 or 0.2. And because the test has a margin of error, it's not uncommon that if you do the same test over and over, you can see a change of 0.1, 0.2. And that's why the definition of acute kidney injury involves at least a 50% increase in the creatinine or an increase of at least 0.3. So just to account for that margin of error. So that's called stage 1. It could also be diagnosed by just a drop of urine output. If for example, a patient is in the ICU and we are able to track urine output hour to hour, a drop below 0.5, that also signifies stage 1 acute kidney injury. And then as you can see, the severity of acute kidney injury depends on how high the creatinine or how low the urine output. So it could go to stage 2 or stage 3, which is the most severe and that often involves use of dialysis. There's also a classification for chronic kidney disease. Now, there's different classifications. Some of them also involve proteinuria, like how much protein you have in the urine. But the most common one that is used, especially in children and young adults, it depends on that GFR estimation. So as I said, above 90 is considered normal. Between 60 and 89, that's stage 2. And then moderate is stage 3. And finally, the severe is stage 4, which is less than 29 or less, and severe, less than 15, is when we would start considering replacement options like dialysis or kidney transplant. And the classification is important because the level of monitoring depends on the stage of chronic kidney disease. So as a general rule, if your chronic kidney disease is mild, you might need labs every 6 months on average. Certain, vitamin D and bone hormone are done once a year, and kidney function tests are done every 6 months. If you're in stage 3, we monitor every 3 months along with office visits every 3 months. If you're in stage 4, it goes to monthly monitoring. And of course, in stage 5, we sometimes do it even more often, weekly or every other week. That's when we actually decide to meet with the family and go over the options for dialysis or kidney transplant. Creatinine, I mentioned the creatinine as the most common measure of kidney function. Unfortunately, in mitochondrial disease, the creatinine is problematic because creatinine is a substance that your muscle makes. And if you have less muscle mass than average for your age or your height, then your creatinine, if we use it to measure GFR, going to overestimate your GFR. So if we don't do a cystatin C, many patients can have a normal creatinine or maybe high normal. And if we do a GFR, it looks like their kidney function is entirely normal, but they're actually in stage 2 or even stage 3 chronic kidney disease. So that's why cystatin C is essential if we're screening for kidney disease in mitochondrial, especially if the creatinine is high normal or close or borderline. So cystatin C is a substance that is released by all cells, not just the muscle. So that's why it's more accurate. It diagnoses chronic kidney disease sooner than the creatinine, especially in mitochondrial disease. And so it improves the sensitivity and specificity of the test. So this is what a normal filter glomerulus looks like under the microscope, under light microscopy. And this is what we see when we have this lesion called focal segmental glomerulosclerosis. So focal segmental glomerulosclerosis is a descriptive term. Focal means that just some of the filters have scars, and segmental means that you can see not all the filter is scarred, but just a part of the filter is scarred. It's called segmental scarring. It is a descriptive term, and it has different causes in different diseases. In mitochondrial disease, this signals a problem with the podocytes, which are the cells that form the barrier in those filters. And in mitochondrial disease, unlike other patients that have FSGS, treating with steroids would not be effective, not be helpful at all. So it's so important to know the context. If there is suspicion for mitochondrial disease and we see a lesion of FSGS, sometimes the suspicion comes from hearing loss, for example, or from elevated abnormal acid-base balance. So if there's something that just doesn't fit, we have to look into mitochondrial disease as a possibility. And I say that with a caveat that most cases of FSGS are autoimmune nature, but I've seen it over and over that sometimes mitochondrial disease can be missed because people have not had that index of suspicion. So when we have FSGS, the most common reason why we did the biopsy is because of persistently high protein, urine protein. So how do we actually measure the urine protein? The easiest test that is done in most pediatric offices is just a urine dipstick. You can even buy it from CVS and do it yourself if you need to. So that is a semi-quantitative test, which means it doesn't actually tell me exactly what the number is for protein in the urine, but it gives us an idea. It usually read as trace, 1+, 2+, 3+, and 4+. It also does not correct for the concentration of urine. So if that day, you tested your urine in the morning, you have not been drinking, the urine is going to be concentrated, and you might have 1+ or 2+ protein. It doesn't necessarily mean that you have a kidney disease, just be because the urine is concentrated. So we divide them usually, 2+ or less is low grade, 3+ or higher is almost always abnormal. So even if you have concentrated urine. And it's important to note is that this only detects one protein, the albumin. So you could have actually a negative dipstick, but still have proteinuria at tubular, a different type of proteinuria, which we'll talk about in a minute. There are false positives that can happen. We talked about concentrated urine, also alkaline urine. Alkaline urine is in general a good thing. If you're eating healthy, lots of fruits and vegetables, your urine will be alkaline, but it does cause false positives sometimes on the urine dipstick. Also know that antiseptics can cause a false positive. If there's blood in the urine, it can cause false positive. If you just had a CT scan and got IV contrast, that can give you a false positive as well. So there's a lot of false positives that we have to be mindful of. Now, when you see a nephrologist, they're more likely to do a quantitative test at the same time. And the most common test that we do in both children and young adults is the protein creatinine ratio. So this tests for all proteins, not albumin. It's helpful because sometimes other proteins are elevated. The normal is less than 0.2 milligram per milligram in a child above 2 years of age. So if we're testing a child between 6 months and 2 years, up to 0.5 is still considered normal. And below 6 months, even close to 1 could be normal. Nephrotic range, which is high grade, is usually more than 2 milligram per milligram. So that milligram per milligram is we're taking the protein, dividing it by the creatinine in the urine to account for urine concentration. And that is also unfortunately problematic in mitochondrial disease, because if your creatinine in the blood is low because your muscle mass is low, then it's going to be low in the urine as well. So it exaggerates that number a bit. So we tend to account for that by looking at the creatinine in the blood. And if we know that this patient's creatinine is half what it should be, then I would accept the protein creatinine ratio double what it should be. and it's still considered normal. So this is a way to kind of account for that difference. Another test that we do is albumin ratio. So this is most commonly done in adults who have diabetes, but we also do it in mitochondrial disease to try to differentiate how much of the protein in the urine is albumin versus other proteins, and differentiate between tubular versus glomerular proteinuria. And as you can see, the numbers here between less than 30 is normal, above 30 is called moderately increased albuminuria. The old term used to be microalbuminuria, which we don't use anymore. And then severely increases if it's above 100. So we talked there's different types of proteinuria. Some of them are entirely normal, are expected. So if you have fever and you check your urine and you have a bit of protein in the urine, that's entirely normal. You just have to repeat it a couple of weeks later when your infection has resolved. If you've just ran a marathon and then checked your urine for protein, I bet you they're just going to be high protein because of the stress of the exercise. Same thing with dehydration. And then there's a special type of proteinuria that happens in adolescence that is not very clear why it happens in adolescence. But what we know is that it's completely benign. It's called orthostatic proteinuria. So that is when we check the urine protein in the afternoon, usually in post-pubertal adolescent, and it's a bit high, and then we check it first thing in the morning, and that is entirely normal. So this variation from morning urine to afternoon is not a disease. So they've studied those patients for decades, and they don't have any increased risk of kidney disease. It's just a variation of normal that happens in adolescence. And then the one that we actually worry about is the persistent proteinuria. So I check the urine today, it's elevated. I check it 2 weeks from now, it's still elevated. I tell the adolescent, go home, pee just before you go to bed. So I'm getting only the urine that your kidneys produced when you're asleep, and then wake up in the morning and don't do anything else. Go straight to the bathroom and pee in a cup, and that's still elevated. Then that's not orthostatic, and that's the proteinuria that we worry about. So once we know it is a persistent proteinuria, then the question is it tubular or glomerular? So glomerular is a problem with that filter. FSGS causes glomerular proteinuria, which means that there's leakage of protein that is not normal from the filters. And that protein is usually primarily albumin. So if we take a ratio of how much albumin versus all other proteins in the urine, it's going to be more than 40 to 50% albumin. That's glomerular. Tubular is less common, but unfortunately not less common in mitochondrial disease. Mitochondrial disease actually first affects the tubules, so it can cause tubular proteinuria. And in that case, there's increase in other proteins other than albumin. So when you do a ratio, you're going to see that less than 40% of the protein is albumin, and the rest is other things. So you'll see that discrepancy, that the dipstick might be negative or low grade, but the protein creatinine ratio is high. And the other thing that might give you a clue is that if in glomerular proteinuria, because you're losing so much albumin, the albumin in the blood, which is the main protein that we measure in the blood, will be very low. And that suggests, obviously, glomerular. In tubular, even though you lose some albumin, it almost never causes low albumin in the blood. And finally, if you lose a lot of albumin in the urine, albumin goes with other substances called plasmin or enzymes that actually can cause salt retention. So the old thinking was that if you lose albumin in the urine, your albumin in the blood would drop, and that albumin in the blood is what holds on to fluid inside your blood vessel. Unfortunately, the studies have debunked that, and now we know that it's not as simple as the albumin dropped in the blood. You're going to have more swelling in your legs or face. It's actually has to do with the kidney actually retaining too much salt through enzymes that leak with the albumin into the urine. And that's why the treatment, albumin does not always help. It can help if the albumin level in the blood is very, very low. We can give it as an infusion, but most of the time, it's not the treatment for nephrotic syndrome for high albumin in the urine and swelling. And then finally, if you have other symptoms of problem in the initial tubule in the kidney. Those are things like glucose in the urine that's not supposed to be there, low phosphorus levels, so you're wasting phosphorus into the urine. If you have low uric acid levels, or if you have abnormal regulation of acid, all of this will point towards tubular proteinuria as well, because the tubular proteinuria comes sometimes with other abnormalities. When we put them all together, they're called Fanconi syndrome or renal Fanconi. So we'll dig into this also a little bit later. So if you have glomerular proteinuria, and the extreme, most severe manifestation of glomerular proteinuria would be nephrotic syndrome. So nephrotic syndrome is a triad of those three things. You have very high protein in the urine, mainly albumin. You have swelling. So if you press on your legs, you might see that there's a dent in your leg, that extra fluid outside the blood vessels, and that's caused by salt retention. And then you have low albumin in the blood. So this is the extreme form of kidney disease related to proteinuria. And again, if someone presents initially with this triad, the first thing that comes to mind in most nephrologists is going to be an autoimmune disease. And the first thing they will do is probably put you on a steroid. And it's a long course of steroids, usually 12 weeks. So if there's suspicion for mitochondrial disease, it's important to clarify what is the cause, in a clinical setting where there's other signs of mitochondrial disease. Now, in nephrotic syndrome, also you're going to see high lipids, which is very common. Sometimes if you might need treatment to lower the lipids, but and the diet did not seem in this particular high situation. So sometimes if the lipids are very, very high in blood, you might need a medication to lower the lipids. And then because you also lose certain clotting factors, if you have nephrotic syndrome, you would be at risk for clots in the blood vessels. So it's not recommended to routinely start aspirin or an anticoagulant, but this is something also we would consider if someone develops a clot. And because you also lose some of the immunoglobulins, which are a defense mechanism, you're also at increased risk of infection. So any child or a young adult that develops nephrotic syndrome, and it is not something that can be easily controlled, we tend to recommend vaccines like pneumococcal vaccine protect them from certain infections that are more common if you have nephrotic syndrome. Now, about a decade ago, we've actually discovered mutations that can cause nephrotic syndrome. And these are mutations that are related to the synthesis of coenzyme Q10. So you get some coenzyme from your diet, but most of it is actually synthesized in the mitochondria. And the first mutation that was discovered, which is a CoQ6, codes for an enzyme that actually help you synthesize coenzyme Q10. So it was very, very interesting to see that there's actually forms of nephrotic syndrome that can easily be treated with a supplement, coenzyme Q10. And I say easily, I mean that the treatment actually helps a lot. It in studies reduces the proteinuria by more than 60-70%, and prevented the decline in kidney function, and that could result in needing dialysis early in life. And this is a form of, again, nephrotic syndrome that in the case of coenzyme Q6 occurs usually in the first 2 years of life, and it is treatable with a supplement. So this was certainly a major success, and it's very, very important to think about it if a patient has mitochondrial disease and also has nephrotic syndrome. So again, it's potentially treatable. And then a year later, they discovered another mutation, which was even more interesting, the ADCK4. So that is a mutation that actually also helps synthesize coenzyme Q10. So if you have this mutation, you're not able to synthesize that enzyme, and it also appears to affect only the glomerulus. Sometimes there's no other manifestations except steroid-resistant nephrotic syndrome. The more interesting part is that this happens in adolescents. So, patients can be entirely healthy until early adolescence and then develop nephrotic syndrome, just similar to the autoimmune type of nephrotic syndrome. And the clues are, again, usually hearing loss or seizures or, other signs, sometimes fatigue, prolonged fatigue that could be related to underlying mitochondrial disease. Um, and if we think about it, it's a simple genetic test that we can send, and those patients also in studies respond to coenzyme Q10, so we can treat it with just this supplement. Now, there are problems, obviously, with how coenzyme Q10 is given. The bioavailability, which means like how much your body absorbs of it, is not very good. It varies between patients. And given the rarity of this condition, we don't still know precisely what the best dose for it. But in a small series of patients, it did help, again, reduce proteinuria by more than 2/3 in those patients and delay the need for dialysis. So I'm going to move on to actually the more common manifestation. So glomerular disease, I started with it because it's the most common function that people are aware of. But actually, an issue with electrolytes and acid-base balance is a more common problem in mitochondrial disease. So I want to just go over briefly what the kidney does in terms of acid-base regulation. So there are three main mechanisms to regulate acid in the kidney. One is happens in the first part of the tubules, called the proximal tubule. The proximal tubule is very highly active part, so it has so much mitochondria. It's usually the first part to be affected. And the function here is to reclaim bicarbonate, which means bicarbonate is the buffer in the blood, goes into the urine, and the nephron tries to take this back into the blood to avoid wasting it in the urine. That's called bicarbonate reclamation. And then the distal tubule, which is involved with actually secreting protons, secreting acid in the form of ammonium in the urine. So that's the second way the kidney regulates. And the third part, which is through a hormone called aldosterone, it's in the collecting duct. So the third type is almost never an issue in mitochondrial disease. So I'm not going to discuss it in detail. But you might hear the terms proximal RTA, proximal renal tubular acidosis, is caused by a function problem in the proximal tubule in bicarbonate reclamation. And then distal RTA is a problem with ammonium excretion, is a problem with that distal part of the nephron. Sometimes you might hear also type 1 and type 2. Type 1 is actually the distal, which is confusing, but that's the first one they discovered, so they called it type 1. So how does bicarbonate reclamation happen? So there's an enzyme called carbonic anhydrase that actually splits bicarbonic acid into water and CO2, and CO2 diffuses in, and then there's certain channels that help. The end result is reabsorption of this bicarbonate molecule. Now, what's most important about this is that it almost never happens in isolation. So if you have a problem in the proximal tubular acid-base regulation, you're almost always going to have also a problem with reabsorption of other anion or other substances in the proximal tubule. So those are, we talked about glucose. So if you see glucose just on a dipstick, elevated glucose in the urine with a normal blood glucose, that should raise red flags for proximal RTA. Normally your glucose in the urine should only appear if your blood glucose is above 180 or so. So if your blood glucose is 120 and you have positive glucose in the urine, there's a problem with the proximal tubule. Same thing, we talked about tubular proteinuria. So there are certain amino acids or proteins that are supposed to be reabsorbed. If they're not, you'll see them in the urine, and that causes tubular proteinuria. Phosphorus is reabsorbed in the proximal tubule through a channel called NAPI, and if that is not functioning well, you're going to see wasting of phosphorus in the urine, which is something we can measure, and also low blood phosphorus levels. And then finally, low uric acid, which is another substance that is reabsorbed in the proximal tubule. So commonly in RTA, you have low blood potassium levels. Are we over?
Yeah.
Okay. So symptoms of low blood potassium can be confused with other mitochondrial symptoms. So I thought it's worth mentioning that low potassium levels can increase your risk of arrhythmias, can cause high urine output, so it impairs your urine concentration ability. It can cause muscle weakness and cramps. And sometimes those are brushed as just because you have mitochondrial disease, you have this weakness, but it's important to make sure the potassium levels are also well controlled. And constipation. So just like weak muscles, skeletal muscles, you have weak muscles in your gut, and that causes constipation. Distal acidification is similar. The only difference is that you're excreting H plus in the urine through another type of channel, and that it commonly comes with calcifications in the kidney. So it's called nephrocalcinosis because you also waste calcium in the urine. Distal RTA commonly shows also stones or calcification in the kidney as a clue. Now, H plus is an ion in the urine. It's how the acid gets excreted in the distal convoluted tubule. But if there wasn't ammonia in the urine, it will be reabsorbed. So it's easily reabsorbed into the cells. But because the kidney makes ammonia, it traps that H plus in the urine, and that's how we trap that and be able to excrete the acid in the urine through a molecule called NH4 plus, which is just ammonium. So when we're trying to diagnose distal RTA, because we don't have other clues aside from the calcium, we measure something called the urine anion gap. So we use this concept in chemistry that is not electrically charged. So there's always be the same number of positive ions as negative ions. And if we take the potassium and sodium in the urine, take those measurements, subtract the chloride, we should have a negative number. That negative number suggests that there's ammonium in the urine. So if you have distal RTA, because those unmeasured ions, the ammonium is low, if you do the potassium plus sodium and subtract the chloride, you end up with even, sometimes zero or even a positive number, and that would be highly suspicious for distal RTA. How we diagnose distal RTA. Now, I want to mention that urine anion gap is only helpful if your blood is acidic, if you have abnormal acid levels in the blood. If your levels of acid are normal in the blood, then it doesn't matter what the urine anion gap is. The kidney is doing what it's supposed to do. So it has to be done at the same time as a blood test and correlated with a blood test at the same time. In terms of treatment, the diagnosis is difficult, but the treatment, fortunately, is relatively easy. So we give potassium citrate, which is converted in the liver to bicarbonate, or we give sodium bicarbonate supplements. In young children, it's a challenge. It's easier said than done, giving sodium citrate 3 times a day to a young child. But if we're able to get it in, it buffers the blood and generally helps improve the symptoms and helps slow down the disease. Sometimes large doses are needed, especially in proximal RTA, and sometimes we need phosphorus supplements because the phosphorus is also low. In distal RTA, bicarbonate wasting is usually much slower, which means that they need much less doses of citrate or bicarbonate. And those are much better tolerated. The issue with citrate is that it causes diarrhea in large quantities. So once we hit that diarrhea, then you're losing more bicarb in the stool, and we just have to hit that balance where we're giving just enough to correct the bicarb but not cause a diarrhea. And then in distal RTA, because they have high urine calcium, it's important to, first thing is we don't restrict calcium. And that's a common misconception that the calcium in the urine is high. Let's just cut down on calcium in the diet. And that's a big mistake, especially in children, because they need that calcium to grow. 99% of calcium is in our bones. So it's more important to actually make sure the vitamin D levels are okay, they're not too high, and also make sure that the patient is not getting too much salt, because salt is what drives calcium into the urine and not calcium. In fact, restricting dietary calcium can be harmful because calcium binds oxalate, another substance that can form stones. So if you don't give enough calcium, that oxalate gets absorbed and you end up with more risk of kidney stones. So you're restricting calcium, but you end up with calcium stones. Low salt diet is what we recommend. Limiting animal protein has some role. And thiazides are sometimes used, which is a diuretic that helps lower urine calcium. Fluids obviously are so important. If you have high calcium in the urine, there are guidelines of how much we should target in terms of urine output for each age group. And to target this urine output, we usually add around 16 ounces extra of fluid to just account for losses through the skin and the breathing. Blood pressure is next. So those are the definitions for high blood pressure. For children, they're age-based, based on age and height. And for adults, we would like the blood pressure to be below 120/80. That's the ideal range. Elevated blood pressure is the new term for pre-hypertension, which usually, the urgency is less than obviously having stage 1 or stage 2 hypertension. But controlling blood pressure is one of the few things that can be done if you have chronic kidney disease to slow down the progression of the disease and protect your kidneys. This is, regulation of blood pressure by the kidney. There's release of renin and aldosterone, which is a sequence, and that we have medication that can help correct the blood pressure by blocking different parts of this sequence. But the most important treatment nowadays for kidney disease, especially in children, and especially if you have high protein, is a group of medication called the ACE inhibitors. So those medications block a conversion of angiotensin 1 to angiotensin 2, which is a hormone that constricts your blood vessels. So when you get an ACE inhibitor, your blood vessels tends to relax and get dilated. And they work specifically on a part of the nephron, the efferent arteriole, which is the part that takes blood out of the filter. So if you relax that part, you shunt blood through the filter without having high pressure inside the filter. And that helps lower the proteinuria and helps protect the kidney, because we know proteinuria going through the tubules can cause inflammation and can cause progression of kidney disease. So this is one of the few interventions that actually been shown in large controlled studies to slow down the progression of chronic kidney disease. They should not be taken during pregnancy. That's a big problem with those medications. They do elevate blood potassium and sometimes even creatinine, so we have to watch those numbers closely. They can cause cough, usually in adults. In children, for some reason, they don't have that side effects. Like I've done this for 12 years and never seen any child complain of cough after an ACE inhibitor. Bone health. So we talked about the 25-hydroxyvitamin D being converted in the kidneys. And then the vitamin D, the active form of vitamin D, helps you with calcium absorption, with bone formation. And they also affect the parathyroid hormone, which is the bone hormone that's released by small glands around your thyroid gland. So often we measure those in chronic kidney disease. We measure PTH, the bone hormone. We measure vitamin D levels and adjust the treatment based on those. Almost all patients with chronic kidney disease require a vitamin D supplement. Vitamin D has a role in bone health, but you can see it has tons of other benefits, not just isolated to the bone or calcium metabolism. Less common manifestations, there's something called tubular interstitial nephritis that we see rarely in mitochondrial disease. I've seen just a few cases of tubular interstitial nephritis. You can see there's infiltration of the kidney with inflammatory cells. And if you do electron microscopy, which is very high magnification, you can actually see the mitochondria that look entirely abnormal. There's also a condition called Bartter-like, which has been reported in Kearns-Sayre syndrome. So this is a very special situation where you have a problem with the proximal tubule, but you have, for some reason, the mitochondria in the collecting duct are completely intact. So it happens that, different tissues have different affection of mitochondria, different heteroplasmy, that's the term they use. And if the collecting duct is entirely intact, what happens is that you get all the salt that was not absorbed will get to the collecting duct, and under the effect of a hormone called aldosterone, you actually reabsorb that salt in exchange for H+, which is the acid. So you end up, instead of having excessive acid, you have excessively alkaline blood. And that's what is similar to a genetic condition called Bartter syndrome. It's also very similar to being on Lasix. If you're on Lasix, you get exactly the same electrolyte abnormalities. So the treatment is actually to provide chloride as sodium chloride or potassium chloride, essentially the exact opposite of what we do in RTA. So that's aldosterone effect, absorption of sodium in exchange for potassium and H+. So this is a review. I took that from a review from Austria. It's a very, very helpful table that tells you what has been reported in different forms of mitochondrial disease. And, the bottom line is that RTA is very common in most presentations of mitochondrial disease. Renal tubular acidosis is common. And as you can see, there are certain rare presentations that are only specific to certain disorder, like Bartter-like syndrome, for example, in Kearns-Sayre. But this is a table that I often even refer to, when to see what has been reported. If it's not reported, it doesn't necessarily mean that it could never happen, but it just, helps us in terms of the diagnosis. So the bottom line is that all patients with suspected mitochondrial disease should be screened for kidney dysfunction at presentation. Those should include the BUN, which is a kidney function test, creatinine, electrolytes, magnesium, phosphorus, and the urine protein. That's at a minimum. And in most cases, I also do a cystatin C. I do both forms of urine protein creatinine ratio and albumin creatinine ratio. In patients who have progressive advanced kidney disease, we sit with the family and we talk about the different options. So there are two forms of dialysis that are an option, and then there's a kidney transplant. And this is a shared decision making between the provider and the family. So it is not necessary that dialysis is a good option for all patients. It's just, it depends on goals. What are your short or long-term goals? At the end, we want the best quality of life, short-term and long-term. And hemodialysis is an option. It requires a vascular access. It's done in the dialysis unit usually, so you'd have to come to the dialysis unit 3 times a week. In adults, they do home hemodialysis as well, but in pediatrics, that's not an option. It's a more less gentle form of dialysis because you have to remove all the fluid in 3-4 hours, as opposed to peritoneal dialysis, which is done every night at home. So peritoneal dialysis uses the peritoneal membrane, that sac around the abdominal organs, as a filter. We use a machine that places fluid inside the abdomen. Sits there for usually 40 minutes and then gets drained and goes through cycles throughout the night. You do it when you're asleep. So for children who are attending school, it's certainly much better for them to be able to attend school while doing the dialysis. Unfortunately, the fluid that we use for peritoneal dialysis has a high lactate concentration. So if you have a mitochondrial disease with complex 1 deficiency, it can be difficult to handle that extra lactate and cause acidosis. And as far as I'm aware, there's no option right now specific for mitochondrial disease without lactate, but hopefully that will come in the future. And finally, kidney transplant. So it usually provides the best long-term option. It helps patients grow the best, children especially. But at the same time, it's a major procedure. In mitochondrial disease, there's always that risk of arrhythmia and decompensation during or immediately after the procedure because of the anesthesia and because of the stress of the procedure. So it is not pure, and it is, it's very important to talk about the benefits and risks openly and make the best decision possible for each particular patient. So, I really do think that I see it over and over because kidney disease does not give you any symptoms. And most of us would only go to the doctor if we are feeling bad, and if there's no symptoms, things can get delayed for years. I do want to emphasize, as just to conclude this presentation, is that kidney disease, even though in chronic kidney disease is not completely reversible, it is treatable. There are treatments that can help. If detected early, the treatment is much easier to help prevent manifestations, but also to slow down the progression of chronic kidney disease. If you detect it early, it's a matter of just monitoring every 6 months. But if patients who present very late when they have symptoms, sometimes the only options we have are dialysis.